Welcome everybody. All hear me? So welcome. That's gone 11 o'clock, so I think we'll make a wee start. So thank you for coming today to the part 2 of our We Safe to Start webinars, which is part of a series of Healthcare Improvement Scotland's winter webinars. This webinar is a part of a series of webinars that's to provide a platform to promote and share good practice from across the work of Healthcare Improvement Scotland and the health boards in response to the current and anticipated system pressures, with the ultimate goal of maintaining safe, high quality healthcare. Next slide, please. So I would like to take this opportunity to invite you all to pop into the chat who you are and where you're tuning in from while I run through some of the housekeeping. We have a few housekeeping rules today. So just a reminder that today's webinar is being recorded and will be available to view following this event. Please, if you could ensure your camera and your microphone are switched off, just to avoid any interruption to the presentations. There will be an opportunity at the end of today's session for questions and answers. So you're able to use the raise the hand function at that point. We do encourage participation in the chat box and have someone monitoring the chat box for questions that we will include in the question and answer session at the end. We also have someone monitoring the chat box for anyone having technical issues, with the option also to email to request technical support. Next slide, please. Sorry, back slide, please. So excellence in care and the health and care staffing legislation share a common purpose to ensure the provision of safe and high quality healthcare, and that the health and well-being of staff and patients is supported through a framework of continuous improvement and assurance. The Excellence in Care framework is based on the premise that in order to achieve excellence in care, all of the elements within the framework are interlinked and are of equal importance. No one would dispute the fact that in order to deliver safe, high-quality healthcare, we need to have an enabled workforce working in sufficient numbers and skill mix. The assessment of real-time staffing requirements, decision-making, mitigations and risk escalation is a legislative duty within the soon-to-be enacted Health and Care Staffing Act and is a key component of most board safety huddles. Excellence in Care's vision and framework highlights the importance of creating the culture and conditions in which healthcare can flourish. The focus of today's webinar is on the vital elements of leadership and the promotion of a culture of psychological safety and transparency that not only improves the quality of care, but also improves staff well-being, which is so important at this time of workforce challenge. All of these elements are vital elements highlighted within Care National. Slide, please. So I have the great pleasure of inviting our first speaker, who is Nancy Burns. Nancy is a senior programme advisor within the Health and Care Staffing Programme with over 30 years of experience as a registered nurse. Nancy is going to share with us some of her observations and reflections from her experience in providing workforce expertise to Healthcare Improvement Scotland's Quality Assurance Directorate during their recent acute hospital safe delivery of care inspections. Thank you, Nancy.
Thank you. And can you hear me all right?
I can.
Yeah. So thank you for inviting me today. I'm really delighted to share with you our observations, reflections and findings whilst we've been out on inspection. Next slide, please. So Caroline alluded to the fact that as healthcare staffing were brought in to support the 7 work streams, as you can see in the slide, of the Quality Assurance Directorate, and that's obviously because workforce is becoming an increasing challenge, and I don't need to tell MD on this call the significant workforce pressures that everyone's experienced. So as highlighted in the slide, today's talk will be around what we see on inspection when we are doing the safe delivery acute hospital inspections. So in the spirit of true transparency, it's important to let you know that Morag, who's on the call with me today, and Morag Francis is one of my wonderful colleagues who's with me in this work stream, that we are not inspectors, and they have their own unique and collective knowledge and skills, that carry out the inspections. So, but it has been a steep learning curve for Morag and I. However, it's been made much easier by the support, the encouragement, they've been so welcoming, and the inspectors are really appreciative of the contributions we've made. So the next step in the process is I'll take you through what we've observed and the data we've gathered whilst out in inspection. And following on from that, we'll discuss our findings and observations before concluding with our reflections. So this side, so the webinar in this series will build upon that community of learning and opportunity to share ideas. And create that kind of community of learning. And we've also put in the chat the learning system, which will support this further. So important to acknowledge, and I don't need to tell MD on this call, that the system is under extreme and relentless pressures. However, what is really clear is that the boards, the leaders, the teams, the individuals are working incredibly hard to deliver care and services in the best way they possibly can. So this slide takes you through our high-level process of what the Healthcare Staffing Programme team review, including the data and evidence gathered, which will hopefully help to provide the context, the background, and how the workforce concerns and that direct correlation with the safe delivery of care, patient experience, patient outcomes, and staff well-being. So the first one I want to look at is the safety huddle, and I'm not going to go into great detail on that because last week, or in the first Safe to Start webinars, I have spoke very eloquently about their observations, which reflect our own. And as you'll all know, the staffing discussions, which form part of the safety huddle, will bring me on to real-time staffing arrangements. So the next bit is real-time staffing arrangements. So what is it? It is around described as a mechanism for recording, reporting real-time workforce challenges, demands, risks, mitigations, and escalations. And people ask frequently, why is that important? And my answer is it's simply good governance, but it's also good practice and will be, as Caroline alluded to, a requirement of the Health and Care Staffing Scotland Act 2019. And that's also including the capturing of severe and recurring risk. So I suppose the interesting part is for people on the call is what is it we're actually observing. So this is just a kind of brief description, but we will look at, do the teams understand the aim and the purpose of real-time staffing? How are the staffing risks reported and recorded, including those severe and recurring risks? An important aspect is, what is the culture? So what's that threshold for reporting staffing risks? And how are staffing decisions communicated to the wider team for people who don't go to the safety huddle? And is there psychological safety? So have the conditions been put in place to support that? So does it feel okay to say we're not okay today without fear, judgment, retribution? Do staff understand their accountability in applying professional judgment? I'm always quite astonished to when I speak to teams to say they don't understand how that aligns with a professional code of conduct. So is there a measurement of patient dependency complexity to support that triangulation of how these decisions are made? And what are the oversight arrangements? And that is really critical. So who's sponsoring it? Who's providing that overall professional judgment? And how is quality monitored and measured and triangulated to ensure that those staffing risks are not impacting on patient outcomes, patient experience? So the next bit we look at is high-level workforce data, and we request high-level workforce data, and currently it's limited to nursing, HPs and medical staff, but we are continually looking at ways to improve and getting feedback from boards, and that's working really well because what we want to ensure that what we ask for adds value. Our work closely aligns to our excellence in care colleagues, and the workforce data we request aligns to excellence in care workforce measures. We also can ask for some local workforce data narrative, and we do so when staff have raised a concern, and they frequently do to inspectors. The inspectors are very approachable, or the inspectors note some care delivery issues which relate to workforce. And then as part of our triangulation process, we review the quality data, such as the Excellence in Care, Scottish Patient Safety Programme, the Care Assurance, and staffing concerns that have been reported and captured through the board's risk reporting system. And And the other aspect we look at is surge beds. So we review the impact of surge beds and the over occupancies, if you like. So in terms of the impact on those true staffing requirements, how that impacts on patient safety, patient experience, and the impact on staff well-being. I'll just go on to the next slide, if I may. Okay, thank you. So I appreciate this section of the presentation might be a bit difficult to hear, but these are observations and the intent is very much to support learning and improvement opportunities. So as mentioned earlier, we know there's significant workforce challenges impacting in all services, all staff groups, and all inspections we've undertaken. Vacancies are very high, but highest amongst band 5 registered nursing groups so far with the data we've captured. And they also, registered nurses also report the highest sickness absence rates of all the clinical staff. We note that despite very high supplementary staffing levels, understand why, high use of agency, and obviously we wouldn't have seen that pre-pandemic. Despite that, there remains significant gaps in nursing rosters, again, within the registered nursing group. So in an attempt to boost the overall staffing numbers, it results in more healthcare support workers brought in through supplementary staffing, and that really shifts the skill mix. So on top of that, you've got high percentage of supplementary staff, you know, that perfect storm emerging. And we know through the research and evidence that that can impact on patient outcomes. We've also heard from AHPs. Now, I have to confess that the hospital inspections are observations, and so therefore you're more likely to comment in nursing midwifery rather than AHPs. But AHPs have wanted to engage with the team, inspectors and myself and Morag, and they often speak about they have got significant gaps. Staff speak of having to prioritise care on a daily basis. And we're told that that results in unmet need, loss of rehab potential, impacts on discharge planning. But so far, we haven't been able to gather information on how the staffing risks for these groups, other clinical groups, are monitored or measured, and what the potential impact is on patient outcomes and staff wellbeing. Caveated by that is not to say it's not happening, of course. In all the boards we've inspected, we note that they take their own approach to how they record and report real-time staffing. So we frequently see in hospitals and these are the hospitals that underreport, if you like, the conditions haven't been fully embedded to support those key principles. In these situations, we hear staff talking about more of a tick box exercise. And in boards, again, with low level of risk reported, despite the complexities that we hear, there appears to be a lack of openness and transparency in how the risks are managed and recorded, and that lack of understanding of how their professional code of conduct applies to the professional judgment. So I've got some examples to just put it into some context. So we attend the safety huddle and listen to the extreme challenges that all teams are facing due to the high clinical demand, complexity, staffing gaps, skill mix changes, high supplementary staff, etc. Staff will frequently acknowledge, yeah, we're short, often quickly followed by, but it'll be okay, we are safe to start, and without hearing any mitigations. However, when the inspectors visit the wards, and almost without exception in these situations, the teams they meet are visibly distressed and stressed and state they're not able to deliver essential care, concerned for patient safety, and they're also concerned for their own registration despite not escalating. They feel they're not able to give the care that they feel the patients deserve, and they feel they constantly let them down. And that's the kind of the example that we're coming across around the barriers and blockers. Again, if the foundations haven't been laid and they're not understanding their accountability. And I suppose from an NMC perspective, we'll all know that under the code and preserve safety, they have a duty to raise that concern if there's a patient safety issue. But I suppose I can also take that to the next level of the clinical leaders with professional registration, again in boards with low escalations. And these situations, I haven't heard many challenges, but that's not to say it's not happening, or using that appreciative inquiry approach. So help me understand, I feel, I notice in terms of the level of risk that's been discussed and the decision to say they're safe to start. There are also many examples of how staff normalise staffing, so that comparison. So yesterday I was 4 short, today we're only 2, so absolutely will be fine. When there's problems with staff morale and burnout, there's a bit of disengagement. So what's the point? It doesn't result in me getting any more staff. You know, nothing I say makes a difference. I just can't go on. So we see a real disconnect there. And when there is a lack of clarity and a lack of communication of how that risk is mitigated or managed, staff do not understand how hard leaderships are working every minute of every day to mitigate risk. And that's particularly evident in groups that don't attend a safety huddle. And they are very frustrated. They don't feel valued, cared for, listened to, or feel their risks are acknowledged in any way. And in the staff report in these situations, they are very demoralised. So that is words from teams. So yeah, that's quite a difficult one. But in many boards, there's little evidence how leaderships kind of formally measure or monitor severe and recurring risk and how that aligns to patient outcomes and staff wellbeing. So again, that disconnect. Caroline, you've spoke about this, and I love this analogy that that everyone's on the dance floor and they are, you know, it's just so busy, they're so operation, but then nobody's doing that balcony horizon scanning and looking more strategic. So it's that catch-22. And then finally, I'll move on to the surge beds, and it does feel like a bit of a tipping point, surge beds, albeit I completely understand the rationale for these complex pressures environment, high flow, low capacity, but in each of the inspections of the surge beds, there are significant harms, not only to patients, but to staff wellbeing and morale. The staff requirements, we know they've been considered. However, due to the staffing crisis, the staff intended to support these beds are quickly absorbed into the system. So next slide. Thank you. I've talked to you about the situations we've come across. However, on a really positive note, we've seen hospitals who've made those significant changes and to how they create the conditions, report and record staffing risks, and the difference is palpable. So the set of scales is there to represent when all things are equal. So you're comparing, you know, apples with apples. So high occupancy, high front door activity, high dependency, high complexity, workforce challenges. But what's really remarkable, when all things are equal, is the marked difference in staff wellbeing when the systems are created to support the teams. And it does take considerable effort, and we'll hear from the Queen Elizabeth on the steps they took to create those conditions, as well as promoting that psychological safety and that positive reporting culture. And also when staff understand how their professional judgment aligns to the code of conduct, that's also important. And then the accountability, which makes a massive difference, moves from that personal accountability to a corporate accountability with that shared understanding of risks, appears to alleviate stress and distress. And with an open culture of reporting, there's improvements automatically in communication. Staff understand the efforts that have been undertaken and they feel more reassured. It feels like it creates that sense of community, that we're in this together. Important to stress that this does not mean, and I'm sure the Queen Elizabeth will talk about that, doesn't mean to say that the staff aren't concerned with staffing levels or their ability to deliver. It doesn't mean to say they're upset at not, you know, feeling that they're letting the patients down, but that they still are less visibly stressed and distressed because, again, it's moved from a personal risk to a corporate risk. So the oversight is that more of that horizon scanning, understanding if they understand the true risks that are there, and monitoring those severe and recurrent risks, it's that impact on quality, safety and staff wellbeing. So helping with that early intervention and having clear understanding of the mitigations put in place helps with communication. And we heard in the last webinar from Geraldine Marsh that when the staffing risk is known and it's at a severe level, they enact the prioritisation of care, which is also a comfort for teams. And there's a real open and honest connection between what is actually happening within the clinical areas and what the leadership teams feel is happening. So just on to the next slide, please. And it's just my conclusions, and it's just a little bit of what would be the take-home messages. Create the conditions to support real-time staffing. If you build it on soggy foundations, it won't work. Considering your organisation, what are the barriers and blockers? So when you've got low levels of reporting and the background of high complexity, etc., you know, have a think about that. And understanding everyone's professional accountability. I guess there's more training and education required. And that oversight, that horizon scanning, being more proactive. This is obviously caveated because this is very early findings. It's based on observation. It's not a research project, and the number of hospital inspections are still small. But in conclusion, there appears to be a correlation with the conditions that have been created. There's good oversight, a culture of psychological safety that supports open and honest, transparent recording. Acknowledging risks, I think, is really important to staff. Appears less stressed and distressed. So thank you for listening. I'll take you over to Caroline. Sorry, didn't follow my instructions.
Not at all. Thank you very much, Nancy, for sharing with us some of the learning and what is making a real difference to maintaining that safety and quality, but most importantly, our staff well-being in the current climate. Just a wee reminder to everybody here, please do use the chat box to share any thoughts, reflections on what you've heard, and as well to post any questions that we can ask of the panel at the end in our session. So I'm now delighted to welcome and introduce Morag Gardner, who is the Deputy Nurse Director from Greater Glasgow and Clyde, and the team who were really instrumental in creating the conditions within GGC. Morag has been in senior roles in Greater Glasgow and Clyde for the last 5 years and has a nursing career spanning south and north of the border from her previous roles in London, Fife and Lothians. Morag is joined today by Dr. Terri Hunter, who is a senior organisational development advisor and chartered organisational psychologist with over 30 years working in psychology and management consultancy before joining US. Also joined by Kevin Mcauley, who is the associate chief nurse, who in addition to serving in the armed forces for 17 years, has had a varied nursing career specialising in emergency department nursing and developing high performing teams. And we're also joined by John Emmet, who's the senior charge nurse within the orthopaedic trauma unit at the Queen Elizabeth Hospital, and who has 15 years nursing experience within orthopedics. So vast experience there. So we're really delighted to have them along today.
Brilliant. Thanks, Caroline. I'm just opening and really setting the scene for the next 15 minutes. So on behalf of all of us from the Queen Elizabeth University Hospital in Glasgow, we're really pleased and proud to be here to share our story and our journey within the Queen Elizabeth. I suppose in terms of setting the context, our current staffing challenges and our safe to start considerations and difficulties are probably the same as yours. Most days we have a number of wards, a high number of wards that aren't safe to start, and we have situations where we have one registered nurse that we need to support and mitigate and remove that and make that a never event. And speaking to many of colleagues across boards in Scotland, I know that that's comparable. So over the next 15 minutes, we're going to share our journey. Terry's going to start by talking about how we created the conditions, the culture and the relationships. And that's been a journey that Terry and I have been on over the past 3 years. We've got bits right, we've got bits wrong, and it very much is an evolving and live thing. Kevin is then going to talk to us about where we are now. So the structure of our huddles, how it looks functionally, and how we enable that sort of honesty and that joint approach to any issues or concerns that are raised, and how we listen to our colleagues. And most importantly, John is going to conclude by letting us all know how this feels, because our senior charge nurses are our most important people. They're the people that facilitate the nurses caring for our patients. So we thought it was really important that John had the final word, and I know he'll be very honest with his reflections. So I'll hand over to Terri. Thank you.
Thank you, Morag. Thank you, Morag. Really appreciate that. And just to sort of set the scene as well, it was quite interesting when Nancy said, you know, to get ourselves off the dance floor and onto the balcony. And I guess sort of 3.5 years ago, that's what Morag sort of commissioned me to help her do with the lead nurse team. So we didn't set off with the intention to build psychological safety per se. We had the intention to generate a high performing team from a team that was very new. So there was lots of new members, there was lots of new movement. Morag was fairly new. I was completely new to GGC in the South. So we had a really good opportunity to think about, we've got a blank canvas, where do we want to be and how do we get there? And I think, as Morag said, it's not been an easy journey, and it's not been a short journey, and we're actually still on it. But it's let us take that time either in the dance floor sometimes when we're looking at some of our immediate processes and how we do things, and then sort of stepping back and looking at that balcony perspective of, are we still in line with our vision and our principles? So we had a kind of, next slide, please, thank you. We had, as I said, the vision to become a high-performing team as a group of lead nurses. Now, there's about 18 of us, and as I said, very keen and all very committed to doing the best for patients, staff, each other. And we wanted to get this really strong idea of what are we about, what do we stand for, and actually, how are we going to behave with each other? So there was a lot of introspection in the team, looking at the things, what we are as a team. And then there was also, well, what are our influencers? What are the things that we need to look at external to the team? So not only our own processes, but also processes that we're involved in, whether at a senior level or not. So we kind of had that both internal, external focus to the team, and would regularly come back to do little sessions. You know, we didn't go away for days. We just did short, sharp sessions, looking at, you know, maybe one piece of theory, getting us to 1 or 2 outcomes at a time, and keeping us really on track. And what you find when we did that is, could I have the next slide, please? That psychological safety kind of fell out the bottom. So obviously psychological safety is part of being a high performing team. And when you look at some of the areas in terms of, you know, that role clarity, which is about mutual accountability, interdependence, that peer support, having the right skills mix, having the right principles and behaviours, and then that learning orientation. How do we actually learn from what we do, and how do we keep that sort of curiosity and inquisitiveness? So we kind of ticked all the boxes as we were doing our high performing team. And one of the things that we're very proud of, and Morag and I felt we couldn't not share with you, is the next slide, please. So one of the things that we're very proud of is our little image of the umbrella. And really, this is what we refer to continually in terms of our lead nurse team, in terms of our processes, in terms of our behaviours. Does our behaviours, processes still align with what we are trying to do? Is what we are doing going to provide the vision and support to guide safe patient-centred care? Because if it isn't, why are we doing it? You know, if we said that's our vision and that's our purpose, why do we want to do something that doesn't align with that? And again, we're very strong in our principles. As you all know, we've got, you know, very clear values in the NHS and GGC. We have our sort of, you know, our 4 buckets of values, but we wanted our own key principles as well that defined what we do in our lead nurse team and beyond. And I think always our intention was that this would cascade, again, our support and our care for each other within the lead nurse team, but then we want to cascade and take that forward into our other teams. And I'm going to hand over to Kevin, who's going to talk you through how we did that in one very specific area.
Thanks, Terri. Good morning, everybody. So I think one of the the main points we had to recognise early on, that there was never going to be one single method of making this work. There was never going to be one person who would make this work. And what we had to do early on was look at a whole team approach to this. So what we've got here in front of us just now is a slide that I suppose kind of outlines how we came to be able to deliver what we're delivering at the moment. And I think even going back maybe 12 months or so, we could see a worsening picture, and we've kind of thought, you know what, we're going to make mistakes, but what we have to do is we have to have a process in place where we can look to involve everybody and record those collective decisions, so we could look at a whole site approach and sharing risk and making things as safe as we could possibly make them. So the first slide there, the first kind of part of that slide there on the left-hand side, this was a pre-safety huddle that we got together with the lead nurse group. And what this did was set the scene for the day where nursing staffing was going to be concerned. Now, a lot of this work went on before the main staffing huddle and included the team as a whole on the ward. So it included the band 6s and 7s, it included the band 2s, 3s and 5s, who would discuss the safety start categorisation to see would they be red, would they be amber, would they be green, so that we knew that everybody had a chance to feed into this picture, this evolving situation. There was a natural escalation from that, so the nurses in charge of the wards would feed that back into the lead nurses for the specialties and the directorates. From that, we would then all get together collectively and we would have what we'd call the staffing huddle. Now, in order to kind of maintain an overall responsibility for that, that would then be chaired by either the chief nurse or the associate chief nurse, and it would be represented, as I said, by each of the specialties, who would in turn give us what the clinical picture was for the day. So they would alert us to how many red wards they would have, or amber wards, or even more, less frequently, recently, green wards if there was any available, and what the volume of nurse staffing or healthcare support staff they would be short. Again, more frequently, we're getting increasing requirements for registered mental health nurses, so it would give us the overall picture. Now, this would give rise to some robust conversations between colleagues, just to see who was potentially in a position to help other areas, which areas maybe couldn't help anybody at all, and actually maybe couldn't help themselves, so we'd need that collective approach to safety. At all times, it's always respectful, it's always open as well, so that everybody feeds into that, nobody sits back and doesn't have their say. And then what we did as a group then was we would assess the risk. Where is the evolving picture? Where's likely to have the biggest concerns maybe later on in the day? At this point, we would look to see, does anybody have an area with one registered nurse on, or is anybody going to an area with one registered nurse on? An overall responsibility, where it's shared by the team as a whole, the chief nurse or the associate chief nurse would then assume that responsibility for the whole site safety, in order to give that reassurance that people had been heard and actually these were the decisions we're probably going to have to make, but it would then be reassessed at various points throughout the day. So from there, we would then move into the whole site huddle, and this would be the main huddle for the sector as a whole. Bearing in mind, we've got the Queen Elizabeth, we've got Gardner, and we've also got the New Victoria Hospital as well, and this was led by the general manager of the day. So from there, we would have various representatives from, whether it's the nursing workforce, whether it's service management, going into things like your ancillary services and diagnostics. We would then have our AHP colleagues there would also feed in to give us a better idea, how the day might be looking, and in order to allow us to then target those limited resources in the best possible way we could. Again, it then allowed us to identify those risks around the sector, so that everybody was aware of what was going on. There was none of that kind of, I suppose, in the more senior leadership roles, you can have that pressure where you have to achieve an objective, but you know what, that tunnel vision maybe isn't always the best thing to have. So this then allowed us to share that among the senior leadership and senior management teams. What we'd also put in place was what we termed the lead nurse of the day. So it's a monthly rota. One of the lead nurses is an overall charge of recording these decisions and the mitigations, sharing them collectively around the teams. What it also does is it gives a kind of one-stop kind of resource for anybody in the senior leadership teams, or going down to the ward level where you've got your senior nurses on the ward, or the band 5 nurses who can look to see at any point what's happened, what's going on. Is anybody actually listening to me here? And that communication is from bottom up and top down. From the site safety huddle, that one that was at 8:35 by the general managers, we would then have the lead nurses and the clinical service managers would leave that huddle and go up into their clinical areas, so that this information could then be promulgated, shared amongst the teams, and it also allowed band 2s and 3s to then escalate any concerns if there's any band 5s worried about anything, if the senior nurses are actually harbouring something that they maybe didn't want to bring up but need to speak to somebody about it. Again, it allows everybody their say. It basically fosters that psychological safety where what you want to say does matter. We might be focusing on one thing, but we're not aware of something else. Everything you've got to say will be listened to. And again, just on that final point there, encouraged to highlight the concerns on the walk round so that we could then record that, because this one huddle at 8:30 in the morning is not the one and the only one. This then carries on to what's highlighted there in, I suppose, the right hand side. So we review this again at 12 o'clock. From 12 o'clock, what we're looking to do then is have a plan in place from earlier on, where we may have highlighted a ward that's maybe dropping to one registered nurse and is actually going to increase that clinical risk for that day, as well as staff wellbeing as well. So from 12 o'clock, what we're looking to do, these generally appear in the afternoon because of early shift finishes, so maybe your 1:30 finish or 3 o'clock finish. So at 12 o'clock we then look to offer that reassurance to the areas who are going to be under the most pressure that here is the plan in place, and before you drop to one registered nurse, our aim is to have you put back up to 2. And you know, again, that can be robust conversations, moving resource from one clinical area who are under pressure to another clinical area who, do you know what, actually they're under a bit more pressure. But again, we discuss it. It's never a diktat. We never say you are going to do this. We try to have the conversation where they understand the reasoning behind it. And then again, that's repeated at 3 o'clock. So by 3 o'clock, we look to make sure that our plans that have been put in place throughout the course of the day from 8 o'clock in the morning have been carried through. If there's been any issues or anything has popped up in the meantime that, you know, maybe we weren't aware of, that we will actually then try and overcome that as best we can. And it's at this point we then look at night shift and we follow exactly the same principles. We forecast what staff we may think are going to come on. We look as a site, as a sector across all 3 sites to see who is potentially going to be able to support any other area in need, and it's wholly transparent. That's recorded at 3 o'clock and is then stored centrally so that the night coordinators who come on actually have a visible evidence of what the plans were going to be, so they're not left to carry that kind of burden overnight should it prove to be challenging. Can I have the next slide, please? I suppose finally what I just kind of want to touch on here is the importance of maintaining that open culture. You know, frank discussions should have to happen, and about maintaining that well-being where we can for staff. So we offer staff support where we can, and these kind of take the format of occupational health and the initiatives that they've got. So they do offer the well-being coaching. I know they offer the counselling service, and they also offer access to the Scottish Government's National Wellbeing Hub as well. There is counselling support available on site, so we've got the chaplaincy service who will be visible round wards, and they'll go and speak to any areas who have maybe highlighted where there's potentially staff struggling. We've got the listening ear service as well, where we can phone up and you've got a 60-minute session where you can actually speak to somebody who's trained to listen. And we also then have the breathing space initiative as well, where staff can look to source maybe additional support from elsewhere. We do have the peer support training where we're trying our best to get our senior leaders on that so that they can maybe take part in what would be good for debriefs, especially at the end of particularly challenging shifts or shifts where maybe, do you know what, things have maybe not worked out the way we would have hoped, and there's potentially been clinical incidents have happened, to allow staff to not take something home with them. So we would sit with them, we would speak, can you please let us know how you feel, get concerns off your chest. And then what we also do is we kind of try to end that on a positive note, but do you know, what did you actually achieve today? Thank you very much for your efforts, and we know it wasn't easy for you, but you know what, you turned up and you gave everything you could, and we can't ask for any more of that. And I suppose what we also look to do as well is just offer that availability of the senior leadership. So we are visible on the wards, we do go and speak to teams, we are available by email, we will attend senior charge nurse meetings, we will attend sector meetings. we offer an open door or an open email policy. Contact us, we'll get back in touch with you. And I suppose finally what we wanted to do as well was just, it's something we initiated in the South Sector called Together We Care. Now, this was off the back, I suppose, early on of concerns being expressed where, is anybody listening to me? Do you know, what's happening with regards to counselling? What's happening with regards to recruitment? What's happening with regards to the fact we've only got one nurse on a shift? So we reviewed Datex, we reviewed emails, we reviewed kind of common requests for help and support, and we got together in conjunction with partnership with Morag and the kind of senior leadership team, and we answered all of these questions. We basically took each item, we gave an answer back to that, and then we shared that back with all of the teams to say, do you know what, we are listening to you. I know we can't get round every word every day, but here's what you asked us, and here's actually what you don't see, but what we're doing in the meantime. So I suppose that some days this will work, some days this won't work. It's an evolving picture. We will change things as and when we find a better way of doing it. But this is where we are at the moment. And I suppose at the tail end of that, and as Morag quite rightly said, is I've got John Emmet here who will hand over, who's one of our senior charge nurses on the ward. And effectively, these are the guys who give us the information to enable us to try and do what we can for the site safety. John.
Thanks, Kevin. Good morning. I'd just like to go through what it feels like to be involved on the ward floor with regards to the huddle and staffing, etc. from it. So, as Kevin mentioned, prior to the huddle, I work in orthopaedics, so we'll discuss around the floor what wards are read between ourselves, who have the best staff and who need a bit more support. We will kind of devolve the staff around to make sure that everybody's at a kind of level playing field before we collate the numbers and then pass it over to the lead nurse. I've put on the slide there, just do we have confidence in the huddle for the lead nurse to escalate our concerns, as in our skill mix, our acuity on the wards? Do we feel that our feelings are getting portrayed to the main huddle? Before COVID, we were involved in the huddle. Now we're not, and we just want to know that we are getting listened to. I do feel that we are. I feel our lead nurses do portray the wards as they are when they go through. Secondly, is there a collaborative nursing approach to the safe staffing across the site? This is just, I've had staff come up to me and saying, do other directorates, do other wards help out? It just feels like we are helping out. There's nobody else. It just seems that we're the only ward helping, or we're the only sector helping. Directorate, sorry, helping. So it was just to make sure we pass over after we the lead nurse feeds back from the huddle to us at our safety brief at 9 o'clock. We pass over to the staff kind of what wards were read. We keep the huddle open so they can kind of see what wards were affected throughout the day, and we kind of go through who helps and who didn't help and what help we are getting. It's the same as the other way is, sometimes you feel like you're constantly sending staff to other wards and we're not getting kind of reciprocated back to, we feel we're short staffed. And it's just trying to give the staff the reassurance that, yes, we may feel short staffed at the moment, but there is wards worse off than us. And I think when the whole staffing issues happened several months ago, or a long time ago anyway, staff were kind of apprehensive about going across to these wards to helping out. They were kind of, oh, it's my turn, I don't want to go. So you're trying to reassure them that they would have support to go. And I know from colleagues across different directorates that the senior charge nurses go and help these other wards, the charge nurses and the band 5. So it's all the staff who do go across. But I've found more recently now that staff are more amenable to going to help these other areas. They've been there, they've understood the pressures for everywhere else. So there's kind of more an openness and a more kind of helpfulness to go across. So it's changed from this, I feel I must go, to, yes, I do want to help out my other colleagues. So they do see it as a whole site, helping across the whole site and not just specific areas. Just with the safe environment to speak up with the anxieties, it's just we have an open door policy with the wards across all directorates, and it's just to make sure that staff always know to come in and speak to us if they do have these concerns. And as Kevin was saying about from the bottom to the top and the top to the bottom, about with being informed of the important topics, recruitment together, we care, things like that. This gets filtered down to the senior charge nurses. We then escalate this or filter this on down to all from the band 2s to the band 6s. And usually what I do with my ward is once a month we have the lead nurse has a senior charge nurse meeting. Then a few days after that, I'll have a staff ward meeting. And then what we've got from the lead nurse, I'll pass then over to the more junior staff and everybody else on the ward. Thank you. I'll hand back to Caroline.
Thank you very much. And I think on behalf of everyone, you know, just a huge thank you for coming along today and sharing your journey and really that demonstrable leadership and teamwork with the common goal of maintaining safe and effective staffing, which, you know, you didn't make that sound easy, but you made it sound like a really joined up approach. And I know from discussions with Nancy, that really was demonstrated through Healthcare Improvement Scotland visited Greater Glasgow and Clyde, and just congratulations to you and the team. I've now got the pleasure of inviting you to stay on and join our panel, and hopefully Nancy will be joining us too, and hopefully we've got some questions and answers. We've got some posted in the chat. Just a wee reminder that people can pop up their hands if they want to ask their question directly. Otherwise, I will come to Ben in the first instance to ask the first question from the chat box.
Hi everybody. So we had a couple of generic questions come through, which Tracy has picked up in the chat around can we share the slides and can we share the recordings. So that's been picked up and sorted. But most of the questions have came from Morag, Kevin, Terri and John. So the first one that we've got here was from Shirley, who's helped me with the questions. So she's jumping in herself, multitasking and showing off, which is good. She says, thanks to you for sharing the huddle process. How did you then inform and support staff with their moves to other areas?
I don't mind taking that. So I think in the initial stages, it was pretty difficult because you've got a group of staff there who are specialists in their own area, and it's a very daunting and it's an anxious time for them moving into the unknown where they don't really know what they're going to be doing. So I suppose the reassurance was there, and to manage the anxieties, we kind of covered the guiding principles and you know what, here's what you expect. We would also have additional support available where possible, i.e. we would try to, I suppose, give them an understanding of what would be expected. So if you're going to DME or you were going to surgery, you were going to medicine, what sort of patient cohort was going to be there. And you know what, at the end of the day, we're a nurse, and I get the anxiety that's going to be there, but all you need to do is your fundamentals and do the best you can. Nobody's expecting you to be a specialist in the area. Moving on from that, what we recognised as well was that if we had an area who were going to have staffing difficulties on a day, it was very rarely just one day. The chances were they were going to be having ongoing chronic staffing issues. So what we then looked at was potentially putting them in for short periods of time so that they had a chance to build up that working relationship. They got the familiarity with the ward, the colleagues, they got to know their patient group. So again, it was just it was a kind of ongoing process that, and I think as John said there, just on his own presentation, we're at the stage now where the staff, because it's been happening for as long, maybe don't always enjoy it, but they appreciate what's happened, and they're the first to say we want to give the safest possible care we can. Well, do you know, asking you to move actually is what we need to do to give the safest possible care we can in particular areas.
Thanks, Kevin. That's it. It's that collective responsibility, isn't it, for patient care? Thank you. I'll come to Shirley now for the next question.
Yep, and thank you for answering my question as well. And actually, there's quite a few questions in the chat relating to the movement of staff, and so it's probably an issue that most boards are feeling and trying to kind of manage the anxiety and of movement of staff. So I suppose one of the things that's, and I'm generalizing this from one of our questions around both Lisa from our Health Improvement Scotland team and also Brenda from the Jubilee, they're talking about the well-being of staff, and you've already kind of highlighted and also you both articulated that you're listening to staff and that their voices are being heard. But have you found, and Brenda particularly asked around the safety issues, does it further impact on staff sickness, absence and attrition? So are you finding with your, I suppose if you're finding, and I'm summarising this, that staff are actually going off unwell and not coming into work if they're having to move because they possibly feeling not listened to around the moves?
I'll come to Morag and then Nancy for wider. Thanks.
I can pick that one up, Kevin, and you can come in. So, you know, in terms of that sort of hierarchy of movement, listen to what John was saying. We'll always try and move staff within their own directorates so that there's a good skill set. If not, we'll try and have the next best skill fit so that staff are going to an area where they feel comfortable and competent. I suppose, like many boards, we learned a huge amount during COVID when we had to remobilise our theatre and our crit care staff. And I think, you know, exactly as I think it's Brenda was saying, yes, we did find that our sickness absence rates went up. So learning from the first wave of COVID, the second wave of COVID, you know, what could we do to make that different? So we set up skill stations, we then had, you know, every time that our theatre nurse was put into a ward environment, their lead nurse would actually go round and almost do a care round for the staff, you know. So have you been orientated? Do you know who you go to if you've got an issue? Do you know when you're getting your break? Do you know where the toilets are? So actually almost doing that care rounding for staff that were going out to unfamiliar areas. So we just kept on that sort of open dialogue, because we were finding that staff go back to their areas, they moan to their senior charge nurse or moan to their lead nurse. And what we were trying to do then is understand what those issues were, because pragmatically we knew that we had to continue to support staff across our system. And so if pragmatically that's the decision, how do we make it as, you know, as best as we possibly could do? Again, because, you know, if you get happy staff, you get happy patients, hopefully. So, you know, trying to do everything that we could, but, you know, without a doubt, you know, nurses are individuals. You know, the majority of nurses like working within their team, within the area that they chose to work. So, you know, I wouldn't be honest if I didn't say that it does have an effect in terms of sickness absence. But we continue to learn with some of the sort of generic things that Kevin's described in terms of the support from the system. But really importantly, it's looking at our lead nurses and senior charge nurses who know their staff to provide that sort of welfare and well-being. The other thing that we've done, just again, as Kevin alluded to, is in the areas that have got ongoing absence or vacancies, is we're actually asking people to go for a month at a time or 2 months at a time, to create that sort of consistency for both the environment that's receiving help, but also mentally to help that staff member prepare for where they're going, what their terms and conditions are going to be like, and to give them as much stability as we possibly can do.
Thanks, Morag. And it is that, can we make that a definite link between staff being moved and staff attrition or staff absence? But I think it is doing as much as we can and creating as much of a positive culture that makes staff feel that impact's minimised. And I think I'm hearing that strongly. From your experience, Nancy, from looking at all of the workforce data that you review as part of the inspections, is that something that you've seen? I know it's a loose correlation. We're not building an evidence base here, but are you seeing a correlation between boards that have a positive culture and staff with their staff versus the attrition and absence rates?
Yeah, we're not really collecting turnover as much. We've got, when we do some deep dives into area, we can see areas that have got real challenges and the staff are very discontented and really stressed and distressed. We're seeing very high turnover, but we don't do it as a high level. So therefore it's difficult to compare and contrast. But I suppose I just want to kind of, you know, those take-home messages that what Glasgow and Clyde and we heard from Western General makes a difference. It's palpable. Staff feeling listened to, heard. The risks are still the same and the challenges are still the same, but knowing that, yeah, they're in it together makes a difference. So creating the conditions are really critical.
Kevin, do you want to come back in?
Yeah, I think just taking to add to what was said there, potentially didn't make it clear, Jude. When we're asking people to move or members of staff to move, we'll generally make an ask and ask a volunteer. So it's very rare that we're actually telling somebody you are moving to Ward X because you're required to go. What we'll do is we'll put forward the clinical picture, we'll put the ask out there. So it tends to be less the people who are being asked to move that are maybe going off sick. What you find is the receiving areas who have been under maybe prolonged pressures of high activity and low staffing. It's potentially those guys that are maybe going off. So really we're kind of trying to encourage the movement in order to save the receiving area from becoming, you know, worse. I suppose it's the try to stop.
Thanks, Kevin. Went back on mute at the last wee moment there, but I think we might have caught. I think we've maybe got time for just one last question. What we'll do is we'll try and collect all the questions at the end, and we'll try and get answers back to everybody following the event. So maybe one last question if I just pass to Ben for a quick question.
Thanks, Caroline. So we've got a question here from Jacqueline in NHS Grampian. She said, have you found any measurable change in incidents, etc., on the wards where this new process has been implemented, or has the focus mainly been on employee well-being?
Again, I'll start. So actually this is a site and sector-wide initiative, so we haven't just been trying it or piloting it in one particular area. We look to support the whole of the sector across the 3 sites, as Kevin explained. So looking at our sort of quality and safety data, our safety data has showed no impact. You know, it's maybe not shown the improvement that it was showing 3 years ago, but it hasn't shown any detriment across any of the main sort of safety and harm metrics at all. In terms of quality, patients will tell you that they're waiting longer to get a call bell answered. They're maybe not getting their medication as quickly as they would like it. And conversely, the staff will tell you exactly the same, that they're not able to give, you know, those care fundamentals to, you know, to the level and the timeliness that they would wish to do so. So without a doubt, there are quality concerns, but in terms of safety and harm, I'm not seeing anything and not feeling anything. And we've continued with the measurement of the data, the feedback from our staff, from our patients, and also we've carried on with our sort of our care assurance visits as well. So going out and having a look at the care environments and sort of triangulating all of that. So we haven't identified anything, and probably like everybody else, we're very, you know, we're on the watch out for safety or care issues to happen, because, you know, going back to, I don't know who was talking about normalising and poor staffing and poor care. We really haven't normalised poor staffing and poor care, which I think gives us the tension on a day-to-day basis. But I think that's a correct tension, because we've not lowered, you know, where that sort of line in the sand is for our nurses.
That's a lovely way, I think, to end today's session on. I can't thank all of our speakers enough for today. I'm sure we could have had even more time in this subject. It's clearly something everyone's very passionate about today. So a massive thank you for attending today, and to all our participants for engaging in today's event. You will find in the chat box that there's going to be an evaluation survey. We really want to hear feedback to inform our future events. If you value today, if you'd like to see more of similar sessions as today, or what else would you like? We'd love to hear from you. The recording of today's event will be sent out next week and will be put in the chat box here for you to watch again or share with your colleagues. And I also would just like to highlight that our next webinar will take place on the 9th of November. It will be a focus on increasing capacity, so that's surge capacity during extremis, with some real shared learning from the Louisa Jordan. So you'll find the registration link for that also in the chat box. That does bring our today's event to a close. A huge thank you, and I really hope that you all enjoy the rest of your day. Thank you very much.